Hello, everyone. Welcome to Psychology 32 Lifespan Development. We're going to talk about Chapter 5, Infant Biosocial Development. So infancy goes from birth to 2 years. Different textbooks might have different age ranges, but for the purposes of this course, we're going to go from birth to 2. And we're going to talk about some of the physical features, some of the expectations that children go through between the ages of birth to 2. I'm not going to go through every slide in this chapter, purely because most of it is self-explanatory, but there are a few slides that I'd like to spend a little bit more time on. So forgive me if I skip through kind of quickly, but certain facts and figures are things that you can take a look at, and you don't need me to read the slides to you. So average size of children at birth, 7.5 pounds, about 20 inches. Again, this is average. Children double their birth weight by about 4 months and triple by first birthday. Children go very, very fast in the beginning. By 2 years, they are 30 pounds and are between 32 and 36 inches. And again, these are ranges. Obviously, they can be outside of these ranges, but it depends on how far outside of these ranges the child is before we start to anticipate if there's a problem or not. Okay? All right. Babies sleep a lot. The difficult thing with babies when they're first born is that they tend to sleep in chunks. Their bellies can't hold a lot of food. They're tiny. And when I say bellies, I actually mean their stomach inside. And when they're first born, their stomachs can't really stretch. So you can't force them to eat large amounts hoping that they'll be full longer and stay asleep longer. Babies need to eat every couple of hours, so they tend to wake up every couple of hours. Anywhere between 2 and 3 hours, give or take. Some will go as long as 4 in the beginning, but that's rare. And some doctors recommend against that. Always consult your pediatrician. I will not give you medical advice. But with that, they tend to eat about every 2 hours, which means if you think about a 24-hour day, you're only getting 2 hours of sleep at a time. And sometimes they're up for 10 or 15 minutes, sometimes they're up for 20 minutes, sometimes they're up for a half hour, an hour. But they sleep a lot, in the beginning at least. And their schedules are off. They really don't know the difference between night and day, especially for the first couple of weeks. So they're up just as much at night as they are in the daytime. Although us as adults tend to get more tired at night, they don't get more tired because, again, they don't know the difference between night and day. They're really not used to being exposed to light very much, right? Because it's dark in the womb. And, they don't really know how to handle it. Okay? All right, where should the baby sleep? There's a big debate about this, co-sleeping versus solo sleeping. And every 5 or 6 years, new research comes out on this, and the recommendations from the American Pediatric Association, the American Medical Association, tend to change. Co-sleeping is when the child sleeps in your bed with you, and solo sleeping is when the child sleeps alone, either in a bassinet or a crib or a pack and play, but they sleep alone. And the current recommendations for children sleeping, at least in the Western world and in the United States, they say ABC. A is for A is for alone, B is for on their back. And I forgot what the C stands for. I'm blanking. Give me a second. It'll come back to me. But it's always alone, always on their back in the beginning. And I'm really blanking on what the C is. But anyway, the point is that you don't want any cover. Oh, and don't have any covers. I think that's what the C is. You don't want anything in the crib that could cover the baby's face, that could wrap the baby's neck and strangle them. You don't want to take a chance that anything is going to suffocate the child. When they're very, very young, they don't have the strength or the ability to roll themselves back over. And this is important because, again, the American Medical Association directives have changed over time. Originally, the baby would sleep on their back. And then certain babies at times were getting heads that were a little bit misshapen because their heads are malleable. They can sort of move around over time. The bones in the head can move around over time because they're not totally fused together. And if you sleep on your back long enough, it's possible that the head can get a little bit misshapen. So then they started to put babies on their stomach. When they put babies on their stomach, ultimately what would happen would be they would potentially suffocate. right? So then they started to put babies on their backs again, and now the current directives is on their back. A lot of the time the baby is wrapped in a swaddle blanket, and it's basically when you take the baby and you tuck its legs in, then you fold the blanket to cover one arm and keep that against the body, then you fold the blanket the other way. It's hard to explain without showing it to you. Then you fold the other way, wrapping the other arm against the baby's body, but so that one arm is not touching the other, and it kind of locks them in place and prevents them from rolling over. And it does take practice to swaddle. Some babies love being swaddled. Some babies really don't like it at all, but they usually in the hospital teach you how to swaddle your child because it is a common way for infants to sleep. Now, co-sleeping, which is very, very common in a lot of other countries. It's very common in certain African countries, not all. It's very common in certain Middle Eastern countries, not all. And what co-sleeping is when the baby sleeps in the same bed as you. A lot of parents choose to co-sleep. The big fear with co-sleeping is that you might roll over onto the child, or that the child can suffocate from rebreathing, meaning you're breathing out the carbon monoxide and the child breathes that in, and it can overwhelm the child. And the newer research argues that co-sleeping is dangerous. Again, I always recommend going back to your pediatrician, asking them what the best thing to do is. In all likelihood, they're going to recommend solo sleeping. And you'll hear stories, I co-slept with all my children and they turned out fine, and that's common, right? You always hear anecdotal evidence, you always hear stories, people argue on behalf of that. I can really just tell you what is recommended by the American Medical Association now, and that is solo sleeping. Benefits and drawbacks to co-sleeping versus solo sleeping. So with co-sleeping, research has indicated that children who co-sleep tend to fall asleep faster, but they tend to wake up more frequently. Another benefit to co-sleeping is that children tend to form more of a bond with the parents, and the parent can tend to form more of an emotional bond with the child. Now, solo sleeping, it's kind of the reverse. Children who solo sleep tend to take longer to fall asleep, but they tend to fall asleep for longer, and they're less likely to wake up in the middle of the night. They don't tend to have that direct bond with the parents, and it's not to say that they can't develop that bond. They usually almost always do. But that bond tends to happen a little bit more quickly, I guess, with co-sleeping than it does with solo sleeping. And again, the argument is that they're going to be safer. Children who engage in solo sleeping tend to be safer. So, all right, let's keep going. Brain development. Now, this is pretty straightforward. Brain's communication system is made up of neurons, a fancy word for nerves. Most of the neurons are found in the outer layer of the brain. The brain grows very, very quickly. And there are a lot more neurons present at birth than the child needs. And so what happens to the brain as the child grows up is a process called transient exuberance and pruning. What I mean by that is transient exuberance is the process where neurons grow what we call dendrites. Dendrites are those finger-like things on the neurons that receive information from either the senses or from other neurons in the brain. And the more finger-like things, the more dendrites that the neuron has, the more receptive they are to information. Okay? So if you stimulate a particular area of the brain, that brain's neurons will grow dendrites and be more responsive to that information. And I'll give you an example of how that works in real life. So any one of us could be a botanist, right? An expert in plants. Before we're a botanist, if I showed you 5 trees that looked similar, you probably wouldn't be able to tell the difference because you're not an expert in trees, especially if they look alike. But a botanist, on the other hand, who's been trained to tell the difference, can actually see a difference in the trees, and they can see it very quickly, and it's very clear and very distinct. The reason why is, after repeated exposure to different trees, the botanist's brain can actually change in a way that allows them to see these subtle differences very, very clearly. Now, if I continue to expose you to trees again and again, eventually you would start to see the difference. Another example of that might be identical twins. If you see identical twins once, it's hard to tell them apart. But if you spend time with these identical twins, after a while, your brain is able to tell the difference. And you can see these subtle differences very, very quickly. I worked with a pair of identical twins once, and when I first met them, it was impossible for me to tell them apart. After working with them for a certain amount of time, I could tell them apart from 200 feet away. It didn't take anything. And I could see one and know which one that was versus the other. And again, it's because your brain adapts to stimuli. It gets better at perceiving stimuli, processing stimuli that it's exposed to more. And this is not just about visual stimuli. This can happen with sounds. People who tune pianos, they don't necessarily hear better than anybody else does, but their brains have been trained to hear subtle differences better than brains that haven't been trained. Same thing with people with tastes, right? Professional food critics, they have very what we call refined palates. These are palates that have been they're masticatory, their mouth, their oral sensory receptors have been trained, and the brain changes to interpret the stimuli coming to it more precisely. Okay. Now, the other part of transient exuberance is pruning. There's that phrase, if you don't use it, you lose it. What happens with pruning is if you don't use a particular area of the brain, the neurons in that area either die off because they haven't been stimulated or relocate themselves to an area that's being used. So your brain is constantly remapping and changing shape. And what can happen is if you don't use an area long enough pruning can occur where that area will be limited for the rest of your life. There was this great story, not great, but very interesting story, I should say, about a gentleman who was born blind, or he lost his sight, I think, very, very young, maybe at a year or two. And he lived his life without sight. And then finally, he must have been in his 30s, and they finally developed a procedure that gave him sight back. And he could see, once the procedure was done, he could see. And he was living, in a sighted world again for the first time. And the interesting thing was that he could see shapes, he could see colors, he could identify letters and things like that. But one thing that he experienced was something called face blindness. And face blindness is an inability to recognize faces. So he could look at two faces that looked completely different, and he couldn't tell them apart. If you asked him to describe the features, he could say, oh, you have blue eyes, you have brown eyes, your skin is darker in complexion, your skin is lighter in complexion. But he could not say, oh, that's Adam's face, and that's Angela's face. His brain couldn't process the differences. Faces are very complicated. And it's, there's sort of an entire area of the brain that's responsible, the entire area of the visual cortex in the brain that's responsible for processing and interpreting faces. And he just did not have the ability to process and interpret faces. So you could be staring right at him. He could have seen you 50 times in a row, and he can't tell you who you are unless he closes his eyes and listens to your voice. So it's kind of an interesting process. And the reason that happened was because the area in his brain responsible for processing faces hadn't been used, and in essence was pruned. It was sort of trimmed off. Okay? All right. The last area of the brain to develop is the prefrontal cortex. That's the very, very front of the brain. It's above your eyes and sort of right behind your forehead. I'll talk more about the effects that this can have on human behavior later on, but just know that this is the last area to develop. And if there's any type of interruption in brain development, the brain goes through a process called head sparing. So head sparing is the process in which if you're losing resources or don't have enough resources to kind of thrive, what will happen with head sparing is your brain will channel all of the calories, or as many of the calories as it can, that you get in through food, in this case most likely milk, and it will use all of those calories to support brain growth and brain development, because the body assumes that the brain is the most important part of it, so it'll move those calories or channel those calories towards brain growth and brain development. So your physical size might not grow as quickly, but it's less likely that your brain would be affected by this lack of calories in food. Now, obviously, if the lack of calories in food is severe enough, the brain will be affected as well. But head sparing is a way that your body goes through self-preservation in order to provide the brain with nutrients when it needs. All right. Now, how does your child take in the world? Through sensation and perception. Again, super simple, super straightforward. There are 5 senses, right? Seeing, hearing, touching, tasting, and smelling. And which sense is least developed at birth? It's going to be vision. And the reason why is, if you think back to the transient exuberance process that we talked about before, vision is not activated in the brain. So the area is in the womb. So the area responsible for seeing doesn't get stimulated. It doesn't go through transient exuberance, meaning the dendrites don't grow, making it easier for the individual to see and process visual information. So, because it's dark in the womb, and so it takes a while. And so the vision is least developed because you can't really see. The sense that's most developed is hearing, because the baby is very well stimulated with sound while it's in the uterus. Even though the uterus provides some insulation, sounds do get in there and they get through. Okay, so the auditory cortex gets very well stimulated. Transient exuberance happens there, and the brain does a very good job at processing auditory information, and the baby can hear very, very well when they're born. Okay, now motor skills. Motor is a fancy word for movement. Developmental psychologists pay a lot of attention to motor skills as the baby grows and develops. The baby doesn't have really any voluntary control over anything when he or she is born. Everything that they do are reflexes, okay? Everything. From you put something in the baby's hand and they'll grasp, they'll hold on to it. You put something in the baby's mouth, they'll suck on it without thinking about it. If you startle the baby, it will throw his or her arms out and his or her legs out and then tuck in. These are all reflexes. The baby has no control. They can't hold their own head up. They can't turn in the direction that they want to turn in. They can't let go of things. If they want to let go, they automatically grasp onto them. And this is normal. This is natural. At a certain point, the baby should be developing voluntary movements. They should start doing things on their own. Now, these reflexes take months, even sometimes a year or two to wear off. But the baby should start to do things on their own. And noticing the baby developing what they call voluntary control over their movements is an indication of development. It's an indication of muscle development. It's an indication of tendon development, right? It's an indication of ligament development. It's an indication of brain development, okay? Because the brain has to control this stuff, right? And as the baby learns to develop a certain amount of control over his or her movements, this is an indication of development. It's what we call a gross indication, meaning sort of a big picture indication. And if it's not working, if the baby's not developing voluntary control over a certain period of time, it can be caused by any number of things. If it doesn't develop at a certain period of time, for example, if a baby doesn't walk at a certain period of time, if a baby doesn't sit up at a certain period of time, if a baby doesn't start holding a bottle by a certain period of time or crawling, if it's far enough outside of that period, because there's always ranges, then we know something's wrong. We don't know what's wrong, but we know something is wrong. And so at least that's an indication, and then we can start to try to figure out what that thing might be, what might be causing it, and theoretically how to fix it. Okay? Now, I normally go into a whole thing about Mickey Mouse and reflexes and everything that the baby needs, and I'll just tell you super quick. One thing to understand is that although the baby doesn't have the ability to care for him or herself, the baby is born with something that helps him or her to survive. The thing that it's born with that helps him or her to survive, and it sounds silly to say, is cuteness. Okay, and I always use this example. So this is 2 different versions of the cartoon character Mickey Mouse. The first one is Steamboat Willie, the original drawing, and then this is a version of Mickey Mouse today. If you look carefully at the 2 different drawings and you start to notice the difference, one of the major features of this new Mickey Mouse is that it looks like a human baby if you look at it carefully enough. If you look at a baby, babies you tend to see their tongue quite a bit, their mouths are open, they tend to have really big eyes, they tend to have these little pot bellies. Mickey looks very much like a human baby. Steamboat Willie, on the other hand, really doesn't look like a human baby at all. Looks more like a sort of middle-aged male, right? Typical carrying weight sort of lower around the hips, longer sort of leg to body ratio. Certainly don't see those big eyes. You certainly don't see the tongue. Doesn't look like a baby at all. Now, this is not an accident. Either through research or practice, Mickey's features have become more infant-like. And one thing that does is it sort of triggers this unconscious reflex that human beings have to take care of something, right? If you see a baby, a lot of the time, it's just reflexive. You want to pick it up, you want to hold it, you want to take care of it, and think about it. If you were a parent trying to pick out a toy for a child, which toy would you pick out? One that looks like this or one that looks like this? And why? Well, psychologists, especially evolutionary psychologists, would argue that unconsciously this toy is triggering that reflexive, almost biological love that we have for a child. And I hate to say love, but that's the best adjective I can think of. But it triggers that need to care for. And so it makes it more likely for us to attach to this figure, feel safe with this figure, want this figure in our house, rather than this one, which is quite mouse-like. Not many people really want mice in their house, although some people do. But between the two, we're more likely to want this one over this one. And so what the baby brings into the world are reflexes, enough reflexes to help them survive, and to help them feed, to help them sleep, to help them clear their airway if they need to, which we'll go through in a minute. So they're born with that, but they're also born with the sort of features that elicit care from others because they need to be provided for by somebody else. They can't hunt and gather food on their own, right? Reptilian babies, if you've ever seen a baby alligator or a baby shark or something like that, they are born with everything they need to take care of themselves. A baby alligator is born, it can hunt, it can kill, it's got teeth, it's got armor, it's got a good immune system. And it just swims away from the mother and it hatches from the egg, swims away, and hunts little fish. And as it gets bigger, it hunts bigger fish or other animals. It's born with everything it needs to survive. Since humans and mammals aren't born with the actual skill sets and tools they need to survive, they need to elicit care from others. And this is how they do it, by looking cute. Now, reflexes. We said that many of the baby's movements that they're born with are reflexes, involuntary movements that they don't control. There's two types of reflexes, what we call essential and non-essential. Essential reflexes are reflexes that are necessary for survival, and non-essential reflexes are reflexes that are left over from possibly an earlier evolutionary time, but they are not needed to survive. Okay? All right. Here are the big reflexes that the baby's born with. Breathing, obviously a reflex, that's essential. Hiccups, where everyone knows what hiccup is, where they people argue that this might be clearing of the airway. Sneezing, right? Biologically, this can be defense against bacteria or viruses for the cold. Difficult to say if it's essential or not. Thrashing, where the baby will throw its arms and legs out, moving the covers off of the baby's body or anything off of the baby's body if it's too warm to regulate body temperature. The Babinski reflex. So this is an interesting one. When the baby's very young, if you take the baby's foot and stroke the side of the foot from, let's say, the heel to the toe on the outside edge of the foot, what should happen is that the baby's toes will fan out. They'll separate from each other and then come back together. That's called the Babinski reflex, named after the guy that discovered it. This is a normal reflex. Babies have this. They test for this when the baby is newborn, when they're an infant. With most babies, it's fine. They check it. They don't even say anything to you. If the Babinski reflex doesn't work, if it's not happening, they might take the baby for further testing because it could be indicative of a number of things. It might be nothing. but it could be indicative of a number of things, possibly even neurological. Tucking in is when the babies move their legs toward the body. This could be either for self-protection if they feel threatened in some way, or for temperature regulation. Stepping, I will show you a video later with my son in it who's demonstrating the stepping reflex. But basically, with the stepping reflex, if you touch the bottom of the baby's feet with anything, they will automatically step down. Totally reflexive. Sucking, that's also in the video I'm going to show you later. Basically, if you put anything in the baby's mouth that's big enough, they will suck on it. Simple. Rooting, that's a reflex that the baby's typically born with. And what happens with the rooting reflex is if you stroke the baby's cheek, if you rub it gently, the baby is going to do two things. They're going to turn their face toward the cheek that's being stroked. So if you stroke the left cheek, they'll turn their face to the left. If you stroke the right cheek, they'll turn their face to the right, and then they'll open their mouth. This reflex makes it a lot easier to breastfeed. So typically what you're going to do with a baby is, an infant, especially newborn, is not going to know to open its mouth when the bottle gets towards its face. It doesn't know what the bottle is, or when the nipple gets towards its face. If you're breastfeeding, it doesn't know what that is. It doesn't know what to do. But one thing that you can do with the baby is you can gently rub the nipple from the breast or the nipple from the bottle against the baby's cheek, and they'll open their mouth really wide and turn in that direction. And then when they open really wide, that's when you put the bottle in their mouth or the nipple in their mouth from the breast. Okay. The Moro or the startle reflex, if you startle the baby, if something moves quickly, if there's a loud noise, they tend to throw their arms and legs out and then tuck in. Again, this is theoretically their only form of protection. The palmar or the grasping reflex, if you put anything in the baby's hand small enough for them to hold, they're going to grab onto it. Totally reflexive. I'll show you that in the video also. Spitting up, if too much goes in or if they start to choke, the baby will spit up. And then last is swallowing. Obviously, if the baby will swallow anything that goes into its mouth, assuming that it's not too much and doesn't block their airway. So they will swallow anything that comes into their mouths. Okay, and that's why you have to be very careful what you feed them, because they're very indiscriminate with what they will take in. Okay. All right. Now, gross and fine motor movements or motor skills. Gross are big movements like waving your arms and legs and your head. Fine are intricate movements like fingers and toes and mouth, etc. So the big question is, when we talk about voluntary movements, not reflexes, right? Reflexes happen on their own. We talk about voluntary movements and watching for developmental milestones. Which do you think comes first, gross or fine? The answer is fine. The baby will develop voluntary control over some movement before they develop, over some fine movements before they develop voluntary control over gross movements. And the one area that they develop fine motor control over first is the mouth. And if you think about it, it makes sense, right? The baby is using his or her mouth most frequently, most often. That's the most important thing in the beginning. They don't need to do anything else. They just need to eat, right? And that's vital, right? It's crucial for survival. So the baby will develop fine motor movement, and in the area of the mouth particularly. After that, it'll be probably gross motor movement. They tend to develop the ability to support their own head, hold it up so it doesn't flop back. Then they tend to get basic arm movements down and things like that. But fine comes first, then gross. And then it goes sort of back and forth. Then some fine, then some gross, depending on what the area of the body is that you're talking about. All right. Mouth is first. And then after the mouth advances, they move their hands about excitedly, so that's gross. I didn't have the head up here, but the head tends to come just after mouth, right? The baby gets the ability to hold their head up at least a little bit, and they can start to turn it a little bit. At about 3 months, babies can touch what they're reaching for. 4 months they can grab, but the timing is off. 6 months they can grab and hold on to almost anything. 6 to 9, grab and hold on to anything, even things that are inappropriate, like earrings that dangle, like bra straps if they're exposed, or blouses or shirts or anything. And then by about the second year, end of, middle of the first, grasping or grabbing becomes more selective. They start to choose what they're going to grab a little bit more carefully. Okay. Now, walking. Let's talk about that. First thing to think about is, what's a typical age for a baby to walk, or what is the common age that babies walk? And the answer to that is 1 year. Okay. Now you always hear stories. My baby walked at 7 or 8 months. My baby didn't walk until 1 year and 4 months. Again, there's ranges to this. Okay, and that's normal, right? Everybody is different. We only start to get concerned if it takes an exceedingly long period of time, and that's something to defer to the pediatricians about. You're going to be getting checkups in the beginning, it's every couple of weeks, and then after that, you get a 3 month, 6 month, 9 month, 1 year, and then I don't remember if it's 15 months or 1.5 years, but you will ask the pediatrician, my child is making this progress. And that's one of the big things. Are they making progress towards walking? It's not just about if they're walking or not. It's, are they doing the army crawl? Are they rolling over? Are they starting to scoot around? Are they sitting up? All of these things are developmental milestones that the child is going to reach. So in essence, typically 1 year is when the child walks. And we define walking not just by taking a step and not falling down. We define walking as 3 unaided steps. And this is crucial because children will pull themselves up. They'll hold on to things. They'll take a step. They will engage in behavior called cruising, where they hold on to anything they can hold on to. If there's a little push toy, or if there's a chair or a side rail or something they can hold on to, and they'll walk while holding on to this. This is something that's aiding their walking, and when they're doing this, it's not considered walking. It's called cruising. Once the baby lets go and takes 3 steps, consecutive steps, 1, 2, 3, and then falls on their own, that's walking. So prior to that, that's not officially walking. And the reason why we have this clear definition is because, we really want to be able to clearly define something. When we're talking about science, and we're talking about research, we're talking about validity, we're talking about measurability. How do you know? If walking is just taking your first step, did they take their first step if they held on to something and moved their foot? Did they take their first step if they weren't holding on to anything? Is cruising walking? It's difficult to say. If you create a consistent measure, and I'm not saying this is the best measure, but if you create a consistent measure that other people can be mindful of, that other people can see, that other people can observe, it becomes more objective, and then it gives us sort of, I don't want to say a baseline, but it gives us a way to measure against, and you measure how, typically when the average baby walks, when they take the 3 unaided steps, and commonly it's about 1 year. Okay. All right. We're going to spend some time talking about SIDS for a second, because this is an important topic. So SIDS is an acronym for Sudden Infant Death Syndrome. And what SIDS really stands for is not one thing. It stands for a group of causes of infant mortality. Some are preventable, some we know, some we just don't know. But SIDS ultimately is a group of things that contribute to or cause infant mortality when it's especially unexpected infant mortality, right? Obviously, we never expect infant mortality, but I'm not talking about things like disease. I'm talking about sort of these sudden things that happen quickly. Now, SIDS is never 100% preventable, unfortunately. But there are certainly things that we know cause SIDS, and reducing or avoiding exposure to those things or controlling for those things could significantly reduce the instances of SIDS, could reduce the number of infant mortalities that we see in 1 year. So I'm going to go over what the research says now, and this is pretty up-to-date research. Okay, first, sleeping on the stomach. We talked about this before. Okay, secondhand smoke. Babies' lungs are very inefficient, and they don't actually get as efficient as adult lungs are until late adolescence, usually 17, 18, 19. So smoke that an adult can tolerate when they breathe in and out, that won't overwhelm them, can overwhelm and suffocate a child. Secondhand smoke, smoking around a baby, could cause the baby to suffocate, in essence, and never wake up. Deep sleep from digesting hard-to-digest foods like cow's milk rather than breast milk, or formula. Formula and breast milk are both engineered so that the baby can digest them. They don't have the protein levels and the fat levels that cow's milk has. Cow's milk tends to be very, very fatty, because if you think about it, a baby is going to put on a couple of pounds in 1 year. A baby calf is going to put on, 200 pounds in 1 year. Think about the amount of protein in that. Infants should not be drinking straight cow's milk. Now, there is cow's milk in formula, but it's been altered in a way, or watered down or adjusted where the baby can handle this. But regular cow's milk is not for babies, okay, especially not newborns. All right. Too many serotonin receptors. There's some research to indicate that, we know that serotonin is responsible for a couple of different things related to homeostasis, related to steady state. So it's partly responsible for digestion. Certainly it attributes to mood. It contributes to the sleep-wake cycle, etc. But one thing that we have found, or at least research indicates there's a possibility of, is that too many serotonin receptors, to making the brain more sensitive to serotonin, can contribute to SIDS. There's no way to test for this. While the baby is alive, we don't know for sure, but some research indicates that that can be a factor in SIDS. And there's not really much that you can do to prevent this serotonin receptor issue. Okay. Now, prophylactics, things that can help prevent or reduce SIDS. Room sharing without bed sharing, so room sharing without co-sleeping. We're not sure why, and for a lot of these that we're going to talk about, we don't know the reasons why. It could be 14 different things. It could be things working in combination. It could be something else that's causing this. But anyway, what research has shown is that room sharing, babies that sleep in the same bedroom as the parents in the beginning, but don't sleep in the same bed, are at less of a risk for SIDS. And we don't know why. It could be that parents that are concerted enough to have the baby sleep in their room are more likely to take the baby to the doctor, are more likely to take the baby for checkups, or maybe they have more resources than parents that don't. We don't know. We don't know what it is. It's possible that if something's going wrong with the child, being in the same room would be more likely to alert the parents, and the parents can intervene in some way. We don't know what the reason is. We just know that statistically, infants that share a room with their parents in the beginning at least are less likely to develop SIDS, or are less likely to suffer from SIDS. Pacifier use. For some reason, pacifier use during sleep time, it tends to reduce the risk of SIDS. Don't know why. Really don't know why, but pacifier use tends to reduce the risk of SIDS, and there are different types of pacifiers. The pacifier that was recommended to us in the hospital were these green round pacifiers, and they need to be age appropriate. The thickness of the rubber in the pacifier changes as the baby's age. The size of the pacifier tends to change also, so just double check if the pacifier that you're using is age appropriate, because they do change. The ones that you use when they're super newborn can't be used when they get older, because the ones that you use when the super newborn tend to be very, very soft. And what can happen is, as the babies start to teethe, and their bite reflex gets stronger, they can actually bite through this pacifier and inhale or swallow it, causing them to suffocate. So when they're very young, it's okay, but when they get older, you have to switch pacifiers to a different age-appropriate pacifier. Breastfeeding. Again, we don't know for sure. There could be so many things contributing to this. However, it seems that babies who breastfeed tend to be less likely to develop SIDS. We don't know if babies who breastfeed would not have developed SIDS anyway. We don't know if it's the breastfeeding that is preventing them from developing SIDS. We have no idea. We just know that there seems to be what we call an inverse correlation between breastfeeding and SIDS. More breastfeeding, less SIDS. We don't know why. Fan use. This is a big one. We don't know why, but apparently fan use tends to reduce SIDS. Okay, and this is not about having the fan blowing directly on their face really hard. It could just be a ceiling fan in the room, or any fan in the room just circulating the air. We don't know what the issue is. It could be one of the nurses in the hospital said that they think that it just reminds the baby to breathe if they stop breathing, the moving air. Somebody else had suggested at one point that it reduces the carbon monoxide concentrations in the air around the baby's face by circulating the air. We don't know what it is, and it could just be, again, coincidental. There could be something else going on there, and it just so happens that it's statistically correlated that fan use and SIDS tend to be inversely correlated. Increased fan use, reduced SIDS, right? That's an inverse correlation. One goes up, the other one goes down. We don't know why, but we do know that increased fan use seems to be associated with a decrease in SIDS. Immunizations, here's one of the big things. There's no indication that immunizations increases the risk of SIDS, and some research indicates that immunizations may actually lower the risk of SIDS. Okay, and we'll talk more about immunizations later, because I know that this is a big topic and a big point of debate when it comes to children and their development. Okay. All right, breastfeeding, the last slide that I'm going to go over in this slide deck. Breast is best. Forgive the sort of silly way of putting it. Research time and time again indicates that breastfeeding is the healthiest and most beneficial thing you can do for your child. Now, there are times and situations where it's not possible to breastfeed, okay? And I'm not chastising anybody for not breastfeeding. I'm not judging anybody, right? That is not the point. I'm talking about what the research indicates. And what the research indicates is that there's nothing that you can do for your child that will have as long of a positive and beneficial impact on the child for the rest of his or her life as breastfeeding will. Breastfeeding tends to increase overall intelligence levels for the rest of the child's life when compared and controlled for socioeconomic factors and education. And now you're always going to hear the same thing. I didn't breastfeed my kid and they're really smart. Yes, that happens. But what the research shows is when you controlled for everything, if you had two groups of children, one group that's breastfed, one group that's not, the average IQs of the breastfed children were higher. And I mean, this is when you controlled for everything. When you controlled for education, when you controlled for overall health, when you controlled for any other type of variables that could be contributing to child development. Children who were breastfed had higher IQs, assuming that IQ measures intelligence, higher levels of intelligence, etc. They tend to have better immune systems. They tend to be less likely to develop obesity. They tend to be less likely to develop diabetes, and this is lifelong. Again, it's not a guarantee. Children who are breastfed can develop diabetes and obesity. It happens. But statistically, they were less likely to develop this. Children who are breastfed tend to have much, much better immune systems. And the reason for this is that if the mother is exposed to a virus, the mother tends to have better immunity than the child does. When the mother is exposed to the virus, they tend to develop an immunity more quickly, and they can actually pass on their immunity to this virus to the child. So if the parent doesn't get sick from being exposed to the virus, it's not likely that the child who's breastfeeding is going to get sick. If the parent does get sick, it's remarkable because the parent and the child typically get sick together. And just after the parent gets better, the child gets better if they're breastfeeding. And you can see it. It's almost overnight. And it's because the mother passes their immunity for this virus to the child through the breast milk. And some research indicates that it actually happens on the surface of the mother's nipple. But it's fascinating to see. They get better right away. Now, breastfeeding is hard. It's a difficult thing. It takes practice. It doesn't happen right away. For some mothers, it's very, very easy, but it can be hard. It can take practice. And, there are people who specialize in breastfeeding coaching. They're called lactation consultants. It's very, very common for parents, for mothers, obviously, to have a difficult time breastfeeding. It's very common for the child to have a difficult time breastfeeding. And they have experts and professionals that are either in the hospital or affiliated with the hospital, or the hospital has access to or can recommend you to use, that will help you breastfeed. They actually do a lot. They make breastfeeding more efficient. They can coach you, tell you what you're doing right, tell you what you're doing wrong. They can help you train the child, because the child doesn't always breastfeed as efficiently as he or she can when they're first born. So there are certain things that you can do to encourage them to breastfeed more efficiently. And it can be very painful for the parents. Lactation consultants can actually help you and show you ways to encourage the child to latch that are less painful in the short run and the long run. Okay, when you start to breastfeed, the mother will produce this very, very thick yellowish substance called colostrum in the beginning. Now, colostrum tends to be very, very high in protein, and it's designed to put weight on the baby very quickly. Part of the reason for this is the babies tend to lose a little bit of weight when they're first born, and that's normal. They'll lose a little bit of weight for the first day or two, maybe even 3 days, and the doctors watch this very carefully. Then you expect them to level off, then you expect them to put weight on quickly. Now, babies don't feed efficiently in the beginning. They don't take a lot in. They don't have big stomachs. So one of the ways that the human body compensates and the mother's body compensates is by producing this very thick colostrum, which ultimately will help pack on the calories of for the child, even if they only eat a little bit of it. There are times where you have to supplement in the beginning. You have to supplement with formula because you're not producing enough breast milk. There are ways to encourage the body to produce more breast milk through pumping. Again, I speak to the physicians, speak to the lactation consultants about this, but just going back to the research, breastfeeding is best. That doesn't mean that if you don't breastfeed your child is guaranteed to be unhealthy and is guaranteed to have all these problems. You can have a very, very healthy, well-adjusted child who, has not been breastfed, and that is fine. Sometimes it's not realistic to think that you can breastfeed. But speaking purely scientifically, breastfeeding tends to be the healthiest thing that you can do for your child. Now, let me talk a little bit about a couple of things. You might get this in the announcements before you see this video. You might get it in the video first. So going forward, I put a second video up of me and my son, so you can see my face in case you don't know what I look like, other than the picture on Blackboard. And I made the video so you can see me and so you can see some of the reflexes that are going on. My son has outgrown some of the reflexes that I talked about, but at least you can see what some of them look like. So you'll see that video. It's not a very long video. It's called supplemental video. The other thing is hopefully you have watched the In the Womb video at this point and you've answered those questions. Those questions are due at the end of the second week of the semester. They'll be graded and you'll get them back. And that is your second deliverable. The first one was a chat room. The second one was those questions, the In the Womb questions. I will be posting a link for the In the Womb video on announcements, so you can find that video. It's free. There are some commercials, but it's free online on YouTube, on National Geographic. And so you can watch that video. It's a little bit long. It's about 90 minutes long, but I show it every semester, and students tend to find it very interesting. They tend to learn a lot. I learned a lot the first time I watched it. I do apologize. The diversity in the video is really not what I would like it to be, but the video is still informative nonetheless. So take a look at that. And again, I'm always up for questions. And hopefully you enjoy this video, and hopefully you enjoy the In the Womb video. Hopefully you have a good week. All right, take care.